Hey guys, Woodruff here. I was asked recently a question in a comment to talk about the difference between maybe mods versus DIC. But a lot of times people get SIRS, and I guess I should have mods in all caps here, but it's all good. I'll go back and fix it later. A lot of times people get confused by all these acronyms when they're learning about them. So I figured I would do a simple break it down and comparison just about these that might help you with some upcoming exams and other things that you have. So first, let's break down each one individually. So first, there's SIRS, which is like systemic inflammatory response system or something along those lines. And SIRS and sepsis are really closely connected. Think of these as this is talking about infection and inflammation. And SIRS officially is just inflammation. SIRS, there's no infection. There's just some sort of systemic inflammation. Whereas sepsis is where you have that systemic inflammation, plus you either have a suspected or a confirmed infection. And you'll want to know what your professor or your textbook talks about this, because sometimes this is a test question where they'll ask specifically about like, what is sepsis versus SIRS? And it's all about the fact that you have inflammation plus an infection. But SIRS is just a state of inflammation in the body, but inflammation in the body never leads to good things. So that's why we kind of watch it. And same, this is just a criteria I got off Google. Please do not copy or write this down if this is not what your textbook says. Always go by your specific textbook or what your professor tells you. So please don't come back and say, well, Miss Woodruff said, I literally just copy and paste this to give it an example. But normally the SIRS criteria goes by either a very high or a very low temperature, because both can be signs of an infection, especially in certain populations like older people. Sometimes they present with a very low temperature because their body's more dysregulated when they starting to have inflammation, or like, because remember, SIRS is kind of like think of it as SIRS is like the peekaboo for infection. There's about to probably be an infection or something not good. And this is your body's way of saying, hey, we're ramping up. Because if you remember, real quick geek out moment is that when inflammation occurs in the body has these gates to keep bad stuff out and bad stuff from coming in. But when inflammation happens, those gates open. And when those gates open, things like bacteria and other things can sneak in. So that's kind of the connection there if you wanted to geek out with me. But you probably don't need to know that in depth for the test. So if that's the only thing you remember because it's cool, I'm sorry, but that's probably not what they're going to say. It's more these concrete details and what you need to know as the nurse that you need to know. But anyway, getting back to it. So SIRS criteria. So remember SIRS, I should have come up with a good mnemonic before this. Yeah, maybe I'll come up, but SIRS does have the I in it. So you could think of like systemic, it's the I for inflammation. I was going to say some weird joke about a SIR, but I'm really going to try not to embarrass myself this early in this video. So let's just go with SIRS and the I for inflammation. So yes. I was going to be like, excuse me, sir. All right, I'm going to stop. So yeah, anyway, I'm going to stop before I embarrass myself and my weirdness comes out. But anyway, really high temp, really low temp. It's also based on heart rate. And keep this in mind because most people think SIRS criteria involves blood pressure. It does not. There's nothing about blood pressure here. It's all about your heart rate, and your heart rate's usually going to be high. So if you do have an opportunity to like have a note card or something like that, it'd be good just to do arrows or when you're studying for this versus, definitely if there's some distinct numbers, you might want to put it down. But to first start studying, a great way to start is just be like temperature high, temperature low, heart rate high, respiratory rate high, things like that. Because otherwise you can get really lost in the numbers and then you're memorizing versus understanding what this means. This is saying when there's inflammation in the body, the temperature goes really high or really low. The heart rate goes up. The respiratory rate goes up, and you can see it's greater than 20. And then similar to the temperature, the white blood cells either go up, inflammation, or low inflammation. So yes. And so this is what you kind of want to do is keep it simple. So SIRS is inflammation, sepsis is inflammation plus a suspected or confirmed infection. Then there's MODS, and MODS is something very different. It's like multiple organ dysfunction, something or other system or something like that. You can Google these things or they're in your textbook, but it's telling you that the organs are failing. And this can happen for a variety of reasons. It can happen as a result of Someone has a heart attack, someone gets an infection, like a really bad sepsis can lead to a MODS. There's a lot of causes. Trauma, like I work a lot in trauma. We get people into multi-organ failure after their traumas. MODS is just really about where there's at least 2 organs that are going into failure at the same time. And most of the time, the organs or the body systems we talk about are the liver, the respiratory system, the kidneys, the heart, the brain or the neurological system, and then the blood or the hematological system. And it's kind of broken down in this picture about what symptoms that you're going to see with each of these. So this is usually the stuff you want to study, because usually a question would go along the lines of, hey, a person has the following, like which of these would be an indication a person is in MODS? And then, give you some of, some of these symptoms, etc. DIC is something completely different. So sepsis, SIRS, and MODS kind of go together hand in hand pretty closely. DIC is kind of something in its own. Think of all of these, if you want, as dysregulation in the body, and it's all different types. Like MODS is dysregulation in the organ systems where they fail. There's some, SIRS and sepsis, there's inflammation and infectious process that's leading to dysregulation in the body. DIC is a dysregulation, but it's specifically in the blood system. There's some other problem in your body that triggers you to go into DIC. DIC is not something that just happens to people. It happens as a result of things, especially if you're a labor and delivery nurse, you're going to see this a lot. Not a lot, I don't want to say a lot, but you're going to see it in moms, that especially when they have fetal demise where the baby doesn't, it dies. This can lead you to go into DIC, or sometimes there's problems in labor that can lead a person to go into DIC. You're also going to maybe see it sometimes, and you can see it sometimes with people that have sepsis, like really severe sepsis, or people that do go into MODS can end up in DIC as a part of their hematological system failing. But, again, the DIC happens first. But anyway, there's always some sort of trigger or cause, and there's lots of them, of things that can cause it. Usually, most of the time, tests don't focus so much on what the cause of the DIC is. It's just understanding what's happening and how we're going to fix it. So the big things that you want to think about for DIC is that what is really going on in the body is that the body is clotting a ton. There's something in the body that sets off this like overreaction that causes you to clot, 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 clot. Well, to make a clot, your body needs materials. And what happens is your body is clotting, 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 and making all these clots to the point that it runs out of clotting materials. Well, why does that matter? Who cares? Good, we're not making any more clots. Well, that's great that we're not making any more clots, but if I don't have the materials to make a clot, I also can't stop bleeding now. Because a clot, as much as a clot just hanging out in my bloodstream isn't helpful, I need to be able to clot off. Like if I get a cut on my arm, I have to have the ability to clot or I won't stop bleeding. So the big thing here is about labs. And I have a slide that's coming next that talks about how to study this stuff. But big things that you want to look at is that for labs, and again, this is something I got off Google. So if this does not match, and ignore the bottom one that says peripheral smear, you never need to know about that. But I couldn't find one that just had the other ones. This was the clearest picture. If it says anything different in your book about this, please always follow your book or your professor. But in general, what we're going to find in DIC is they're going to have low numbers of clotting materials. Platelets are used to make clots, and fibrinogen is used to make clots. So those are going to be low because I've used them all up making a whole lot of clots. But then my INR and my PTT are going to be high. And remember, those are the signs of how long it's going to take me to make a clot. And those are going to be longer. Those are my bleeding times. The higher those are, the more likely that I am to bleed, or again, how long it's going to take me to actually form a clot. So those are going to be high because remember, I'm low on my clotting materials because I've made too many clots, but I'm high in the amount of time it takes to make a clot because I've used up all my materials. So I have not a lot of clotting materials, a whole lot of chance of bleeding, then you're also going to have a D dimer be elevated, because a D dimer is a sign that there's some clots somewhere in the body. And remember, in the beginning of this process, I was doing a whole lot of clotting. So usually my D dimer is going to be elevated. So overall in DIC, they are having there is a whole lot of clotting to the point where you have a whole lot of bleeding. And usually you're not going to usually notice their clotting until they're in the bleeding phase. So like the couple times I've had a patient go into DIC, when I see them, they might have signs of clots. Like sometimes they get all these micro clots in their legs, and then they'll have really poor peripheral pulses. Or for the patient I had, they had no pulse or no flow to their legs. Their like leg was pale because that had clotted off. But also at the same time, my patient was bleeding out of every IV. Like not just like, sometimes if you have an IV and it's like leaking a little bit, I'm not talking about that. I mean, straight up blood. They're also bleeding out of their nose, bleeding out of their mouth. They had blood coming from their eyes. Like any mucous membrane, it's going to start having blood come out. It's not pouring most of the time, knock on wood, but it's definitely constantly oozing. So you have a bunch of clots, so you can have consequences of all those clots, like literally loss of blood flow, but you also have an issue of a whole lot of bleeding. And then it becomes this really hard place because, to fix DIC, it seems like I need to fix the bleeding or the clots, like give them a bunch of blood. But here's the thing, I can give them all the blood in the world, but they don't have the clotting materials that they need. And they already have all these clots within them. So it's this hard balance between, I kind of need to give them some heparin to keep them from clotting, the clots from like blocking my coronary arteries or my brain and causing a stroke. But if I give them the heparin, then I'm also going to make them bleed more, and they're already bleeding to death. And so like it's this really hard balance, and a doctor has to usually make a decision on where are they in this spectrum, and what's going to do more harm than good. And sometimes, we give some blood products and hope that it's going to help, but a lot of times it's a really hard balance. We have to fix the underlying problem. So for example, a lot of times with those labor and delivery situations, until we get the baby out of them, some people won't stop that DIC process and get back straight in the order that they need to get to with their clotting factors until the baby is delivered. So sometimes we have to deliver that baby, and that's what needs to get done. If the underlying issue is like sepsis, we have to get to the bottom of treating that infection, etc. So so this is one that's a little bit more complicated. So how do all these relate? So there are some interconnections here if you're trying to figure out what is all this stuff that's going on. Inflammation and infection can cause MODS or DIC. So sometimes, that's how you might see a connection between them, is that you might say, hey, a patient was in SIRS and then they went into MODS, etc. Eventually. Or like, again, I said infection can lead to DIC, like really severe sepsis. And then a sign of MODS can be DIC. So it's not that DIC causes MODS, but remember, part of MODS is that my body systems are breaking down. And one of my body systems that can break down is the hematological system. So when someone goes into DIC, if someone had DIC but also had other parts of their body that were breaking down or not working, they could qualify or have criteria for MODS, because DIC is a sign that their hematological system isn't working. And let's say they have other signs of a different system not working, they could be in MODS. So DIC can be, not always, but can be a part of MODS. And usually they kind of, some of the other ones relate to each other. Like usually we have the SIRS, the systemic inflammation leads to sepsis. And then there is a period in there, there's like septic shock, things like that. And then MODS, and then often death if it's not fixed. It's not saying that every time you get SIRS, you end up dying, but this is just the progression. So they do connect together like that. So they do have an interconnection where some of them can cause each other or related to each other, but they're all actually separate things. And hopefully I've made it clear. So what should you do when you're studying these? Because these are kind of like hard things to focus on. Like I mentioned, focus on the SIRS criteria. What are the things that someone needs to have to be diagnosed with SIRS? What are those criteria? The respiratory rate, heart rate, white blood cell count, and temperature. Like, what are we looking at there? Sepsis criteria, what does it look like? Or where are common places people might go septic? Most of the time when people have actual true sepsis, the two common places that we often look are going to be urosepsis, especially in that older adult. Like often it's like a UTI that's getting them septic, or pneumonia. Then leading to sepsis. There are other causes of sepsis. People can have wounds, but that's why we have to look at someone head to toe and look for any possible source of infection or problem. Because again, we can all day long give someone antibiotics, but if we're not actually getting to the bottom of the infection, so we need to figure out where the infection is, what is the infection, like what's the bacteria that or virus or whatever is going on, so we can most effectively treat it. For mods, when you're studying, you want to know the criteria that you need to have at least two organs that are, or two organs or two systems that are failing. And then what organ systems are affected and how will I know they're failing? And that's this. So you're going to want to know. And I would not copy and paste this chart or try to remember this. Make something that makes sense to you. And think of this. This makes sense. Okay, my brain, what's my brain's normal function? To think, to keep me awake. If it's not working, what's happening? I'm not awake. I'm confused. I'm not thinking right. All right, my heart, it's supposed to, help pump blood to the rest of my body. Like what does cardiovascular, failure look like? Think heart failure. My heart rate goes up. I'm not pumping as well, so my blood pressure goes down. That kind of stuff. For the respiratory system, think if you haven't learned about ARDS, it's a change in my ability to oxygenate. I'm not going to oxygen as well. My oxygen levels are going to go low. I'm going to start breathing faster. For the liver, it's talking about here about how, you can have the jaundice, think liver failure, my liver enzymes are going to go up. The kidneys, obviously, less urine output, higher urine labs. And then like we talked about with hematological, all my labs being off, I could have signs of DIC, things like that, petechiae, signs that I'm not clotting well. Or that I'm bleeding, etc. So these are the things, like they make it make sense to you, because you can write all these words down word for word, but if it doesn't make sense to you, it's going to be hard to remember. But a question they could give you is that, again, like, hey, a patient has the following symptoms. Do they qualify for mods? Because remember, it has to be two organs, not just one. It has to have two organs failing for them to qualify for that. Then for DIC, know your labs and signs and symptoms. Again, remember early on, they start by doing a lot of clotting and they follow that with doing a lot of bleeding. So you want to kind of know, what does it look like when someone's clotting? What does it look like when someone's bleeding? Where am I going to see this bleeding? Where am I going to see the clotting? What are some of the basic treatments? And I talked about, like, again, they have to look at the difference between giving blood products and then also, because like honestly, sometimes when you give blood products to someone who has DIC, it's kind of like putting a Band-Aid on a hose that has a big leak. It's just not going to necessarily work, but it's a balance. So you're either going to be given some blood products or some platelets, things like that, versus like replacing what's missing, versus heparin. That's the doctor's decision. It's not up to you. And there should never, in my opinion, be a test question that asks you which one, because that is a very difficult multi-factor doctor decision. And then remember, the ultimate treatment for DIC is reversing the cause. So it's never, the heparin doesn't fix DIC. It fixes the problem that's happening as a result of DIC. But the only thing that actually reverses DIC, because otherwise they will keep clotting, bleeding, clotting, bleeding, clotting, bleeding till they die, is reversing whatever is causing the DIC. So we have to get to the bottom of whatever the root cause is. So maybe know some of those causes. So hopefully that helped. I hope that helped clarify and break things down. Always a pleasure to see you guys. I will see you next time. Bye.